Okay. Good evening, everyone. Thank you all for coming. My name is Joseph Katta, second-year ID fellow at USF Infectious Disease and International Medicine. I'll be giving my Monday night talk on trypanosomiasis. So, usually trypanosomiasis is not an infection we're going to really encounter in the United States if we're going to work here. We may see some complications with the chronic phase and cardiomyopathy, given the influx of people coming from Latin America. T.b. rhodesiense, sleeping sickness, has been rarely described in travelers. I'm going to talk a couple slides about just general infections in travelers. It's kind of a review for most of us. This article was published in CID in 2007, and it was published with the help of the GeoSentinel network, which is a satellite surveillance network from the CDC and International Society of Travel Medicine. And basically what it did is it was compiled data of people who were sick enough to go to these travel clinics. The survey took place over a 10-year period. There were 30 sites from all over the world. Took place from 1997 to 2006. It surveyed about 25,000 ill travelers and divided them into four categories: those with a systemic febrile illness, those with a diarrheal illness, dermatological disorders, and lastly a non-GI illness. With systemic febrile illness, malaria was the most common one, and it usually manifests less than 30 days. Plasmodium falciparum accounted for about 65% of the infections of malaria. Plasmodium vivax was the remainder, and usually that presents more than a month because of the dormant stages in the liver. The systemic febrile illness number 2 was dengue, and that was not common in sub-Saharan Africa, but was common. The second most common cause of systemic febrile illness in South America, followed by enteric fever and rickettsial diseases, primarily in sub-Saharan Africa. Manifestations being single or multiple eschars. Here you can see divided into the four categories, and I think it's important to remember that the top 2 or 3 in each category. That way, you could focus your diagnosis on that. Systemic febrile illness being malaria, dengue, mononucleosis either by EBV or CMV, acute diarrhea, parasitic diseases, giardiasis and amoebiasis. Campylobacter was also shown to be represented highly. Dermatological disorders, cutaneous lobar migraines, myiasis, leishmaniasis, and a non-diarrheal GI disorder being strongylosis ascaris or acute hepatitis A. This is basically broken down to like a table format, and you can see basically what I just said in the previous slides. So moving on to my main talk, I'm talking about trypanosomiasis infections. There's basically two main vectors that transmit these diseases. First one is Trypanosomiasis cruzi, which transmits Chagas disease, and you can see the vector being in the family of Reduvial bugs. The vector is the Trypanosome bug, being the top one. The African form is the African trypanosomiasis or sleeping sickness. The vector being the tsetse fly, being on the lower part. It transmits the two gambiense and rhodesiense, which are similar morphologically, but clinically they're different. And staging-wise, it's important to know the staging of them because the treatments are different too, and the clinical courses are vastly different as well. So basically, the trypanosoma in the picture represented there, that's the blood film, and the infective part is the trypamastogote. You see that on blood films, and that's the infective part. The vector transmits that, picks it up. The epimastogotes found in Chagas disease in the midgut of the fly. The amastogotes found in the tissue form, similar with leishmania. With the African form, you only see the trypamastogote. The tritomy vector for Chagas disease is going to nocturnal fever. The bite is usually painless. I'll go more into that in the next couple of slides. Here you can see a slide from the CDC, and basically it breaks down the life cycle of the Chagas infection. You can see here just the trypamastogote's infective form, the tissue form is the amastogote, and basically that's what you see in the blood smear is the trypamastogote. So this was discovered about 100 years ago by a Brazilian physician, Carlos Chagas. He identified the infection in a 2-year-old girl. He found, he was really ahead of his time. He found that the domestic vector in her case was her domestic cat. He was able to isolate the parasite from the cat and the girl, and therefore he was able to describe the cardiac, GI, congenital, and neurological manifestations. He won many awards for his research. In the Western Hemisphere and in Latin America, it's responsible for the highest burden of morbidity and mortality, more than any other parasitic disease and more than malaria. So T. cruzi is transmitted by various species of Trypanosome insects or kissing bugs. They're called kissing bugs because they bite at night near your lips. They're primarily nocturnal feeders. It's isolated from many different species of wild and domestic animals. They're nocturnal feeders, like I said, and their bite is not very painful. It doesn't awaken the host. Transmission occurs basically when the bug breaks the mucous barriers or conjunctiva, and the effective form is actually found in the feces. So it kind of like just bites you, and then the effective form is found in the feces, and that's what gets into the bloodstream. They're able to go in the bloodstream and metabolize to different sites. The cardiac and GI forms are the most important complications. Transmission is either by blood, by the vector, transplantation, congenital, and there have been some cases of oral transmission, mainly in people that were taking contaminated sugarcane, where the sugarcane was contaminated with the vectors or feces, and that's how the oral transmission was documented. So it's strictly a zoonosis, and what that means is that humans are incidental hosts. These vectors have been around for millions of years, and humans acquire the infection by, deforestation and, grazing livestock and, inhabiting land that the vectors normally were. So the vectors are able to live in the dilapidated conditions of the houses, the clay houses, the old primitive wood houses, and they complete their life cycle in the family's domestic animals and the humans. It's estimated that 10 million people are infected and 200 deaths in the last year. About 100,000 of those infections reside in the United States. The vector actually encroaches into the southern half of the United States to South Argentina. But there have only been 6 cases reported in the United States, and that's mainly due to our improved housing conditions. Like I said, they're found in burrows, hollow trees, animal shelters, and humans are incidental hosts. So it's always wondered why, an acute disease, and then many years later, you get chronic disease. And there's 4 theories on why this happens. The first one being direct parasite damage to the myocardium that causes inflammation leading to cell loss and fibrosis. The other one is immunological mechanisms, molecular mimicry between epitopes on the parasite and host antigen. Basically, the epitopes are similar to cardiac tissue, so, causes cross reactions. Cardiac denervation with impaired parasympathetic heart regulation leading to arrhythmias, and microvascular disturbances that are seen in terms of thromboembolism with vasospasm, decreased blood flow, and focal ischemia. So the pathology in acute disease, you have the chagoma, which is an initial inflammatory lesion at the site of entry. The gross examination of the heart reveals bilateral ventricular enlargement, thinning of the walls, apical aneurysms, and mural thrombi. The gross examination of the esophagus reveals a reduction in the number of neurons in the myenteric plexus, parasympathetic denervation leading to dysparalysis and dilatation of those organs. So the clinical course is divided into 3 stages: the acute form, the indeterminate form, and the chronic form. Most people are asymptomatic. Only 1% of people actually get the acute form. Mortality is related to myocarditis. Indeterminate form, most people remain in this and can persist throughout life. 50% of people remain in the indeterminate form. And the chronic form is basically when you develop symptoms in the indeterminate form. And mortality in this stage is exclusively due to heart complications. So the incubation period for the acute disease is about 10 days. The course lasts about 8 to 12 weeks. Patients present with fevers, myalgias, and muscle pain. The chagoma is basically when the parasite enters via a break in the skin. Ramona sign you can see on the right is usually unilateral peridural edema, eyelid swelling, and preauricular adenopathy. Cardiac involvement is 90% in acute disease. You don't have the severe arrhythmias and EKG manifestations. You have the chronic phase. Presents mostly with non-specific ST changes. And then myocarditis causes 5% of the mortality in acute disease. Usually it's self-limiting. You have infection throughout life if not treated, but it resolves in over weeks to months, and normalization to EKG in about a year. Indeterminate phase is basically when you have positive serologies, either with PCR or xenodiagnosis. You can have subpatent parasitemia, and you don't have any gross manifestations, being no cardiac or GI involvement. But if you look at these people a little bit closer, via like Holter monitor, echocardiogram, cardiac MRI, they have subclinical degree of cardiac involvement, but these aren't usually done in these research poor settings. Indeterminate phase can persist throughout life. Chronic phase is basically presents many years later after initial infection, and it's basically thought that the more severe acute phase is, the more likely you're going to get a chronic phase with symptoms. Some estimates state that progression to the indeterminate form to the clinical form is about 2% per year. The heart is the most common organ involved. Most likely, the cardiomyopathy affects the right ventricle. Megaesophagus presents similar to idiopathic achalasia. Symptoms include dysphagia, odynophagia, chest pain, cough, and regurgitation. Megacolon presents with slowly progressive constipation, abdominal pain. And with the chronic phase, even though your parasite levels are low, you still can transmit the infection to the vector or humans, even in the absence of manifestations. So the most important entity is Chagas heart disease. And the Brazilian expert consensus defines this simply by the presence of EKG abnormalities, which I'll show in the next slide, and a positive serology independent of symptoms. Chagas heart disease manifests either with heart failure, arrhythmias, or thromboembolism, originating from the mural thrombi in the heart. Most common EKG abnormalities are PVCs, ventricular arrhythmias, right bundle branch block, and AV block is the most common cause, of Latin America being Chagas disease. Predictors of mortality are impaired left ventricular function by echo and non-sustained VTAC. Usually they monitor these people with twice yearly EKGs, and they recommend 30-second rhythm strip lead 2 just to check for any other indolent arrhythmias not picked up on EKG. So these are the EKG abnormalities. In the previous slide, I talked about the most common. So Chagas heart disease, it's very hard in these settings to diagnose, because they don't have the same tools that are available. Before they were using chest X-ray to look for cardiomegaly, but that was a very non-specific sign. Now that it's recommended in a lot of papers to look for BNP and EKG, but they didn't really go into the levels of BNP that would be correlated. It's recommended, if people have Chagas heart disease, to do Holter monitoring for the detection of the asymptomatic transitory arrhythmias. If you have late-stage chronic disease, like your classification stage 3 or 4, anti-trypanosomal therapy is not recommended. Only supportive treatment for the arrhythmias, heart failure, is recommended. In Latin America, a lot of countries, especially Brazil, they use heart transplantation in very severe forms and ICDs because of the dysarrhythmias. So GI Chagas disease is more common in the southern countries listed there. It's probably due to the Pacific parasitic strains in those countries. The onset is usually 20 to 40 years old. It presents in two forms, megaesophagus, megacolon. The diagnosis is usually with imaging, either a radiograph showing air fluid levels, barium contrast enemas, or manometry. And there's no role for anti-trypanosomal therapy if it manifests in either megacolon or megaesophagus, because the damage is already done. Therapy won't reverse the damage. Symptomatic therapy for megaesophagus, either balloon dilatation of the lower esophageal sphincter, botulism toxin, laparoscopic myomectomy, and treatment of megacolons either by high thyroid diet and management of constipation. So disease in immunosuppressed, immunocompromised, transplanted populations. Basically, if you're in the chronic form and are immunosuppressed, you can reactivate with greater intensity than that seen with acute disease. Some authorities would even favor treatment prior to induction of immunosuppression before transplant. There have only been 19 cases described in the literature of donor-derived infections, and it's important if there is a donor-derived infection, to monitor closely 6 months after transplant. Here in the United States, we don't screen our solid organs for Chagas disease. We screen, from what I read, we only screen our bone marrow. But in Latin American countries, they screen bone marrow and solid organs, and they do use the organs if the donor is positive, but they never use the hearts. Rejection can present similar to paniculatus, skin nodules, febrile episodes, and like I said previously, reactivations with higher levels of parasite replication, and you detect reactivation either by positive blood films or quantitative PCR. With HIV, you can have reactivation if the CD4 count is less than 400. These patients present more similar with neurological manifestations, with a multifocal meningeal encephalitis mimicking PML, tuberculosis meningitis, or cryptomeningitis. There's no role for primary prophylaxis. There's no role for preemptive therapy. You only treat if you have positive signs for reactivation. Secondary prophylaxis, if you have the disease, some authorities would treat until the CD4 count is over 200. So diagnosis in the acute phase is by blood films, parasite detection, either with wet preparations or buffy coat or Giemsa-stain smears. Antibody serologies aren't useful, but PCR assays could be used. Xenodiagnosis also could be used, but that's usually in research settings. And basically what that is they use a sterile vector, then let it feed on the host. They let the trypanosome complete their life cycle. It could take like 4 weeks, or they check the midgut for epimastogotes or the blood for trypanosomes, and it takes like 4 weeks, only in research settings. Sensitivity is only 50%. With congenital infection, it's important to examine the cord blood or PCR. Serology for IgG only can be done at 9 months after maternal antibodies wean. Chronic phase is by IgG antibodies or ELISA. And immunocompromised, like I said previously, if it's reactivation, you have to check the blood films because they have a higher degree of parasitemia, or you can use a quantitative PCR. Here, the slide on the right, you can see PCR peaks very early, like at 0 days, so that would be used for acute infection or immunocompromised or congenital, and then kind of decreases by day 60, kind of when the acute phase resolves. Treatment, there are 2 forms, nephrotox and benizole. Nephrotox is used for acute and congenital disease. It decreases mortality and results in paralogical cure by 50%. There were a lot of treatment dilemmas, kind of who to treat, because the guidelines made by the Brazilian and Argentinian consensus were done like 15 years ago. It's widely, believed that, you treat infants with congenital disease, persons with acute infection, chronically infected children less than 18, reactivating infection if immunocompromised, and those are like the main ones. But now they've been changing their guidelines. Now they treat, indeterminate form with early signs of cardiomyopathy, like stage 1, stage 2 CHF, and they even treat people going up to 50 years old. But they say if it's over 50 years old, it's by a case-by-case basis. Treatment in the indeterminate phase is kind of hard because there's no test of cure. These serologies can remain positive for many years, so it's kind of hard to see if the treatment worked or not. And like I said, GI Chagas with megacolon and megaesophagus, there is no treatment. And late stages cardiac, there's no treatment. So treatment dilemmas, there's a lot of studies to treat indeterminate phases and chronic phases, even in the late stages of cardiac. And the reasons is that therapy reduces inflammatory burden. There's a greater degree of seroconversion after 4 years in a lot of studies. Data showing slower progression to severe cardiomyopathy, decreased parasitism, myocarditis, and less EKG alterations. And a trial is undergoing called the benizole evaluation for interrupting trypanosomiasis, and it's the largest effort to see if it's worthwhile to treat people in the chronic late stages of disease. So moving on to African sleeping sickness. Here you can see the tsetse fly vector on the upper right. It's transmitted only by various species of tsetse flies that belong to the genus Glossina, and these are only found in Africa, so it's a disease exclusive for Africa. It differentiates from T. cruzi because it could go under antigenic variation and multiply in the bloodstream. It's able to change its, basically its, surface glycoprotein coat. So whenever the host mounts an effective immune response, it's able to change it and evade the immune system by antigenic variation. And that way, it results in waves of parasitemia and febrile episodes. Sleeping sickness is caused by dysregulation of the circadian rhythm and fragmentation of the sleeping pattern. In severe disease, you have disappearance of secretion of prolactin, renin, and cortisol. It can manifest neurologically with tremors, fasciculations, hemiparesis, Parkinson-like movements, and speech disorders. So there's two types: TB gambiense, the West African form, which causes about 95% of infections. There's only exclusively a human reservoir, and TB rhodesiense, which is an East African disease. And this is the reservoirs in wild game and cattle. Here you can see the slender replicative forms of the trypanosomes of TB Brucea complex. It only has one stage, which I'll show you in the next slide. And then on the left, you can see the chancre, which is the initial inoculation from the tsetse fly. So here you can see the stages. This is a slide from the CDC, and there's only one form, the trypanosomes. So that's an effective form in all stages. But it's the slender trypanosomes is the reproductive form, and the stumpy one is the one that replicates. So epidemiology, it always has a resurgence because a lot of political instability in Africa and wars. Major epidemics occur in Sudan, Congo, Uganda, and Angola. There have only been about 10,000 cases reported in 2007, which is every year there's lower number of cases reported, but it's really hard to get reliable statistics because these are on the most rural parts of Africa. So they estimate that numbers are 10 times higher, and they estimate about 100,000 deaths per year. Here you can see TB gambiense being on this slide on the east coast, west coast of Africa. The predominant parts being the dark red countries, TB rhodesiense being on the west side. I'm sorry, I said the wrong, east side. So pathogenesis, the chancre is the acute inflammatory lesion that appears 1 week after the bite. It may ulcerate with surrounding lymphadenopathy. It's more common with TB rhodesiense. There are two stages, and it's important to differentiate these stages because treatment is different. Stage 1 is systemic hemolymphatic illness, where the parasites disseminate through the lymphatics and bloodstream. You have widespread lymphadenopathy, which is more commonly seen with TB gambiense. The heart's more commonly involved with TB rhodesiense. You have a polyclonal activation IgM with high titers immunoglobulin in stage 1. Stage 2 is basically when it invades your central nervous system. So the clinical course of gambiense, with stage 1, you have high fevers, intermittent bouts of temperature with extended afebrile episodes. Lymphadenopathy is more predominant. Here you can see Winterbottom sign in the picture, which is basically lymphadenopathy of the posterior cervical chain. Stage 2, could happen a couple, months or years after initial infection. The estimated duration of TB gambiense is 3 years. Basically, with both forms, if they're not treated, death is the ultimate result. So it's important to recognize. But incubation periods with TB gambiense can be longer, up to 10 years. Fever is rarely present in stage 2. So TB rhodesiense, the clinical course is a lot more acute. There's no clear distinction between stage 1 and stage 2 disease. It progresses to stage 2 in a few weeks and death within 6 months if not treated. The lab abnormalities, fever, sleep disturbances, and pruritus are more prominent. Lymph node swelling is not prominent, and you have a higher degree of parasitemia with TB rhodesiense. So duplicate slide. So diagnosis, if you have a chancre or lymph nodes, especially if the lymphadenopathy more present with TB gambiense, you could express fluid, and then you could do a blood smear to examine the motile trypanosomes. This is more likely to be positive with TB rhodesiense because you have higher parasite numbers. To screen populations, you use the card agglutination test for trypanosomiasis, and basically what that is it's agglutination between the dead trypanosome and a specific antibody. They use this to screen large populations, and it's just a finger prick test. You don't have to have blood drawn. The sensitivity is very high in endemic countries, but it doesn't pick up TB rhodesiense. PCR is not available in endemic areas. And basically there are different methods to concentrate the blood. Basically with a blood film, like a thin blood film, you need about 10,000 trypanosomes for it to be positive. With the microhemochrome centrifusion technique, you could use about 500 trypanosomes to be positive. And the miniature ion exchange centrifusion technique is about 50 to 100. But these are only done in specialized areas of Africa. Disease is usually in the rural remote areas. So monitoring is very essential to get CSF in all patients who are diagnosed, because the treatment is different between stage 1 and stage 2 disease. So the first abnormality is CSF pleocytosis. The World Health Organization divides stage 2 disease as more than 5 white blood cells, trypanosomals that are present or increased protein more than 370. If you have to confirm stage 2 disease, you need to be monitored twice yearly and 4 times yearly for both diseases to monitor for evidence of relapse, because it is high because the treatments aren't as efficacious. So here you can see the treatment is different for stage 1 and stage 2. And basically TB rhodesiense, like I said, you could see it in some travelers, especially those to East African game parks. Ceramine is kind of difficult to obtain, so they say you could use pentamidine until you obtain the ceramine medication. So these medications are very old. I don't think any drug administration will approve these nowadays. They're about 50, 60 years old. They have high degrees of mortality, morbidity. The newest medication is ethylfluorine that came out in 1990. And this was a really breakthrough medication, because the old medication to treat stage 2 disease is melaprosol, which was used to treat stage 2 gambiense, and is still used to treat stage 2 rhodesiense. And ethylfluorine replaced melaprosol, and it results in a rapid clearing of parasites from the blood and CNS. Its initial recommendation was IV Q6 hours, which is really hard, to put a PICC line to do a QID drug in these settings. So there was a landmark trial called the NECT trial that showed increased cure rates with Q12 dosing and ethylfluorine combined with nifurtimox. And this was so beneficial that was added to the World Health Organization Essential Medicine list. Ceramine is used to treat stage 1 rhodesiense. It's associated with renal damage. You have to check UAs to check for protein or cast, and if there's any evidence, it should be discontinued. Test dose is given because of immediate anaphylaxis. And melaprosol was previously used for stage 2 gambiense, still used for stage 2 rhodesiense, and has a high degree of mortality with the encephalitic syndrome. Basically manifests with high fever, headache, tremors, seizures, coma. Treatment failure is 30% because of resistance, and about 10% of people who receive this die, so the treatment requires hospitalization. I put that picture there on the right because this shows that this disease is one of the biggest neglected diseases worldwide. There's no good diagnosis, there's no good treatment, and even when this new medication ethylfluorine came out in 1990, the manufacturer saw that there's no money to be made, and they just took it away. And then a couple years later, it showed up in this facial cream used to prevent hair growth. It was on the Dr. Oz show, everything, and there was so much backlash against it that they made the drug free by compassionate care use a couple years later. So prevention is the most important way to eradicate these vectors. You have the Southern Cone Initiative against American Trypanosomiasis. And basically Brazil tried to get rid of their vector in the early 1980s, and they found that they'll never be successful if their neighboring countries have the vector. So they set up this initiative with these countries to control the Chagas vector, encompassed by the whole distribution area of Trypanosoma infestans. And actually they got their model surprisingly from Africa. They copied the onchocercosis control program, which was made before this. 9 African countries united together to get rid of the Simoleon blackfly, the vector for river blindness. So they got their model from Africa, and this resulted in vector-free areas: Uruguay, Chile, Brazil. They screened their blood, from the 1990s, but we here in the United States we started screening in 2006 by the Ortho ELISA. Insecticides, improvement in domestic structures. So they improve the living situation, and they don't use the same housing system they used before. The vectors can't live in the housing confines. For African trypanosomiasis, it's unlikely that any vaccine will be found because of antigenic variation. It's important to eliminate the tsetse fly. They found different ways. Insecticide spraying. They use bait traps, and these bait traps are usually blue because the tsetse flies, they see this from long distances and are attracted to it. And there was some theories about using sterile insect techniques. They actually use this in Zanzibar, like a country off Tanzania, and they were able to wipe out their whole TC5 population by using sterile males, and they got rid of their whole population. But it probably won't be too successful in a large geographical area like Africa. So, a risk of Chagas disease is incredibly rare in travelers because you need at least 2,500 contacts with vectors to result in infection. TB gambiense has been described in the literature in XPA charts that come to Europe. Gambiense has a more indolent form, so they have neurological manifestations. There's been scattered case reports that they have neuropsychological problems and they're admitted to psych wards. TB rhodesiense in people short-term travelers to East African game reserves. So conclusions with Chagas disease, it's important to be aware of the chronic stage cardiomyopathy. TB gambiense is more indolent but causes 95% of infections. TB rhodesiense is more acute, rapid progression to stage 2 disease and death within 6 months if not treated. A rare cause of fever and infection in travelers to game parts. And the main thing to take home is the importance of vector control and halting disease transmission. So, thanks.